My name is Bert Yazzie. I'm a pediatric spine surgeon in Rady's Children's Hospital in San Diego. So scoliosis surgery comes in lots of different forms, but the most traditional way of doing it is using rods and performing what we call a fusion. Basically, the concept is the rods with some screws are used to correct a deformity, hopefully put the spine in a much better position than before surgery. And then the body, what it does is we create this environment to allow the bones within the spine to grow together. And it's both the rods initially and then ultimately the fusion that is what ideally prevents the scoliosis from getting worse. And our goal is really to make this a procedure that will last a lifetime for the patient. The traditional approach for scoliosis right now, probably the one that is most often being performed, is a posterior spinal instrumentation and fusion. And so that's approaching the spine from the back. Other approaches, historically, we've done fusions from the front of the spine. There are rare instances where you may actually have to go to both the front and the back of the spine to perform the fusion. Recently, we've kind of started looking into more fusionless type procedures for scoliosis, and these are actually going back to the front of the spine in an attempt to correct the deformity through allowing the spine to have a controlled way of growing. The spine rods that we use are rigid currently, so across the segments that we do our fusions and we place these rods can result in limited mobility across that section of the spine. What's important to know is that the spine doesn't move across each segment in a similar way, so depending on where those rods get placed may have greater effect on one's mobility. For example, if you place the rods in the thoracic spine, which is kind of the mid to upper part of the spine, there may be a little bit less effective mobility compared to if we ended up having to treat a scoliosis in the lower back, where mobility is much more commonly found. Well, recovering from surgery is probably surgery dependent as well as probably a little bit of patient dependent. Typically what I'll quote for most of my patients with adolescent idiopathic scoliosis, irrespective basically of the procedure that they get, is that by about 3 to 4 weeks they'll feel pretty normal. We don't let them exactly do all the things that they are capable of doing at that point in time, so depending on how you define recovery, usually by 6 weeks I'll let them start doing a little bit of jogging and maybe even a little bit of biking. And then by 3 months, I start letting them go back to their full sporting activities. There may be some discomfort in terms of even 3 to 4 weeks out, but depending on the use of pain medications, some people will use pain medications that may be narcotic, based only in surgery, maybe for the first week, and then transition to some anti-inflammatories. We've had some patients that stop taking all pain medications even within 1 to 2 weeks. So it's going to be a little bit of patient dependent and activity dependence for that particular individual. So when we perform scoliosis surgery, especially the traditional fusion method, it really is meant to be kind of a one and done operation. So we don't necessarily walk into it anticipating that the rods will be removed. And the best way I've described it to kind of my patients is, maybe it's a little bit of a simple analogy, but I'm putting in kind of rebar, and then the fusion is kind of the cement that's being laid down. And the reason why I give that analogy is that removing rods can be as almost of a difficult operation as putting them in, as you can imagine, taking rebar out of cement. So we know that rods are very stable. We know that they can last decades and decades for the entire life of the patient and not cause any particular problems. So we definitely want to stay away from doing unnecessary surgery.